everybody, and welcome today to our webinar, which is Preventing Critical Illness Through Maternal and Infant Vaccinations. So I'm JoJo Taylor, and I work in the immunisation commissioning team. So our team is responsible for commissioning the Section 7A programmes across London and working with partners to improve uptake of vaccinations. So all of those from maternity, childhood, up to our older adult RSV and some of the sexual health vaccines. My role mainly focuses on commissioning immunisations for South West London. And my background is in local authority, public health and children's social care commissioning. And prior to this role, I worked in the regional children's team at NHS England as a transformation project manager, mainly focused on delivering improvements in children's asthma and diabetes. So I'll pass over to Susan.
Hi, and I'm Susan Elden. I'm a public health consultant working in NHS London team as an immunisation lead. And so to complement JoJo's work, where she works primarily on the commissioning and contracting side, I look at some of the wider population health outcomes, some of our partnership models with local authorities, and some of the oversight to look at these kind of bigger strategic outcomes, how we have London's immunization strategy, but also how we're working across partners, local authorities, provider services, and various aspects to provide oversight. So that's me, and I'll hand back to JoJo. Thanks.
So a quick overview of today's webinar. We're going to start with a short Mentimeter quiz. We'll then move on to the importance of immunisation, give you an overview of the current maternal and infant immunisations and a bit of a picture of our uptake and coverage in those. And then finally, some of the issues in access, and then moving on to some time for questions. So the first question we've got for you is, what was the first vaccine to be developed? I can see we've got quite a lot of people going for smallpox and a handful for the others. Most of you are right there. We've got smallpox as the first vaccine. So if we move on to the next one, they might be getting a bit more tricky now. So how many childhood measles cases were there in London in 2024? So we've got 876, 1,336, 2,557 or 4,359. Okay, it looks like most of you have had a chance to answer. So the correct answer was 1,336. So a few of you were thinking that maybe there were more, but that's still quite a large number. Next, we've got what percentage of children in London with confirmed measles have been admitted to hospital since January of this year. So we've got 5%, 24%, 43% or 62%. So this stat comes from our colleagues at the UK Health Security Agency, who regularly monitor all of our admissions as well as cases. So this one actually is 43%, so a huge number really, almost half of those children with confirmed measles were admitted to hospital this year. Next, as today we're going to be talking about children's but also maternal vaccines, we wanted to see how many pertussis vaccines you thought might have been given to pregnant people in London in 24-25. So I've got the numbers at the bottom, so 814, 2256, 3,817 or 5,218, and then I've put the coverage in brackets as well for you, just so you can see roughly how many, the percentage that might be. Okay, so actually we are doing a bit better than some of you think. So we have about 64% coverage with our pertussis programme. That's one of our better programmes in terms of the maternal vaccines. And yeah, so we gave 3,817 vaccines last year, mainly in maternity units. And then finally, what year was the maternal RSV vaccination programme introduced in England? So quite lots of you knowing that it was recent. Joint almost between 2022 and 2024. Okay, so yeah, this came in 2024, so September 2024. So it's been up and running for a year now. So hopefully we'll start to see some of the impact this winter. Great. So I will stop sharing the Menti. Thanks all for your engagement in that. We thought that might be an interesting way to start the webinar and test some of your knowledge. So now I'm going to hand over to Susan, who will talk you through the next few slides.
Thank you. And also that's really helpful for us to have a kind of understanding of folks' sort of baseline knowledge and understanding. So hopefully not too many of those were to catch you out, but even when we were developing this quiz, it was sometimes a surprise to us in terms of, you know, hospital admissions and things like this, because I think there's a lot of things that we assume about different vaccinations, and then there's the sort of reality of that. So I'm going to do a little bit of just a kind of whistle stop tour and a little bit of 101 on vaccinations generally. But bearing in mind that most of you are working in clinical practice, a lot of what we're going to talk about happens outside of the settings you're in, and you're primarily seeing it when vaccinations aren't given and when sort of infectious diseases present themselves in hospital settings. So hopefully we'll have some time to talk a little bit about what that means to you and your experience of when vaccinations don't work well at the population level and the individual level, and how we can get better at promoting that. But just a little bit of 101. So we know that vaccines are important. They're second only to clean water to preventing disease. So it is something that has not just been a national effort, but a global effort to really reduce infectious disease. And I think something that we can all be proud of from a UK and an NHS perspective is they are free at the point of delivery, and that's not true in every country. So in a lot of countries, they haven't introduced some of the levels of vaccines that we have here. And those services and systems haven't provided in that same way. So it is a really important public health intervention, and they're a major cause of reducing infectious disease, both globally as well as here in the UK, and reducing hospitalizations. The biggest challenge that we have now is really about inequalities, because we're increasingly seeing gaps. As we have a growing portfolio of vaccination, we're seeing that there are gaps in both individuals and populations who miss out for various reasons in getting those vaccines and still are presenting with infectious diseases, which can be have lifetime consequences, or in some cases lead to death. Wanted to just show you a little bit about the timeline. So really, I mean, we talked a little bit about the sort of smallpox and some of the very first understandings of vaccination, and then there were diseases like TB, smallpox, things like this that were fairly unknown. Diphtheria is another one from 1942. It's still around with us, very rare, but that is still an infectious disease that we can prevent through vaccination. But I wanted to draw your attention to really where the scientific developments started to ramp up really in the 1950s and onwards, that we saw the science and technology really starting to show the potential for more and more things that we can prevent, and not just infectious diseases, but things like HPV and cancers. And then there's a number of different settings where we can give vaccinations, be it schools, be it sexual health services, and other areas. And that is continuing even today. So some of you may have seen the recent BBC headlines that we'll be introducing the varicella vaccine program, which is going to hopefully help reduce the incidence of chickenpox in our population, and that will be combined with the MMR vaccine for infants and children going forward in the UK. So it is just something to bear in mind, that the portfolio of what was set up at the foundations of the NHS is now much more expanded across the life course, and our systems in order to deliver those things is where we need to kind of keep up that investment, because we have the interventions and the technologies, but we also need to make sure that the recording, the workforce, and the systems are able to keep up with all those technologies. So that has put a strain on things, but it is something that we have the benefit of having these additional vaccines to give. And the next slide just shows a little bit more. I mean, we've talked about the impact on individuals, but it's also about showing these kind of big societal shifts and these population gains from the reduction in infectious disease. So we see a big societal shift from infectious diseases into more chronic and lifestyle because of this. And some of you who may have been working in the past may remember HIB, meningitis C, these sorts of things that you would often see children hospitalized for, but helpfully now are much more rare. But we are seeing, as I said before, we are seeing old diseases emerging like diphtheria. We have seen some cases of that. We haven't seen polio cases, but we have instances of polio being the polio virus being, our detection systems have detected it in the wastewater, and we determined that children needed a booster dose in London as a result of that. So things that we had previously taken for granted, we just need to maintain that clear vigilance and never let up, because as you can see, like, the reductions are huge, but they also are conditioned on high levels of population immunity and our populations trusting us to take up the offer and to vaccinate in order to keep those diseases at bay. I particularly wanted to mention, so those of you, well done on the quiz. We wanted to show you a little bit about how measles has been in the recent sort of 5 or 6 years. And you might notice here that 2024, we did have quite a strong peak, and that came in the early autumn into December. And then 2025, it has carried on, but not to the same peak that it did in 2024. As a result of what was happening, and it was really at the latter end of 2023 and the beginning part of 2024, we started to when we were seeing that rise really in April and May, you're seeing that sort of sharp rise. We identified the children that were missing measles, and we tried to contact the parents and the children, and we expanded our offer in schools. And unfortunately, although we identified about 200,000, what we were able to vaccinate, that we were able to count, was around 2,000 of that. So a very low return of doing that. We do think that the GP systems, which we weren't able to count through their call and recall, were able to access a lot more. And so, again, we're not completely sure about our data, which shows that London has some of the lowest vaccination, but we are helpfully seeing a lower peak in those measles cases. So hopefully what you are seeing on the clinical side is also a reduction in measles cases, but it would be good to hear a little bit more about that in the discussion. And then the second one that I think has an implication for folks in acute settings and working in hospital and other care settings is RSV. And so probably a lot of you have heard about, winter pressures and the various things that we're trying to prevent. RSV, which we introduced in 2024, is given to older adults, and it's given to pregnant women to protect against infant RSV. So this just shows on the left-hand side, London in 2023 and 2024. You can see the 23, 24, sorry, the peak is higher in London. I think we've got, I need to see the, yes, sorry, the 2024 peak was higher. So last year's peak was higher in London, and it was much sharper. And it tends to be sharp right around Christmas time, right about the same time that flu and COVID hit. So it's not helpful. But what we're hoping is that with the gradual introduction of RSV and that population uptick, which is improving over time, that we will start to see that peak flatten out over time, and that London doesn't again bear the largest proportion of those cases. But again, these are RSV reported cases, and what we're trying to do here is really prevent the severity, the hospitalization, and the consequences of that in individuals and populations. And JoJo, I'll hand back over to you then, I think.
Great. So this slide is showing an overview of the current immunisations that are given in pregnancy and to infants. So this is only a small part of the UK immunisation schedule, which covers about 18 different antigens across the life course, so starting in pregnancy and going through to older adults. So on the left, we've got our three pregnancy vaccines. So we've got RSV, pertussis and flu. These are given at different stages throughout a pregnancy to protect the baby against whooping cough and RSV, and then both the parent and the baby for flu. These are mainly given by our maternity units, so all pregnant people should be offered all three vaccines, depending on the time of year, at their antenatal booking appointment. But however, they can also be given by a GP, and soon all three vaccines will be available in some selected pharmacies as well across London. The middle is obviously, there's a lot of different vaccines here. So these are all the different ones given at the different appointments from ages 0 to 5. And this grey dashed box I've got up here is a new appointment that will be coming in from January. So this will be a brand new appointment for babies aged 18 months, where they'll get their 6-in-1 vaccine 4th dose, but also, as Susan mentioned, the MMRV 2nd dose. So that's the MMR with the addition of the varicella for chickenpox. These vaccines here are all given in primary care GP. And then also for children, they can get the seasonal flu vaccine from ages 2 up to year 11. So from reception to year 11 is given in schools. We've got school immunisation providers in London, one covering North London, one covering South. So all children will be offered that at school, but then also our 2- and 3-year-olds can receive that in pharmacies and at GP as well. So alongside these that I've shown here, we've also got a few more kind of selective immunisation programmes for babies that are deemed to be at higher risk of some diseases. So for example, we've got a BCG programme for neonates for TB and also a selective hepatitis B programme. So the next two slides want to give you a bit of a picture on our uptake or coverage of some of these vaccinations in London. So first starting with RSV. So as we know, this was brought in September last year to protect infants, and recent studies that came out earlier this year have shown that actually the vaccine is 72% effective in preventing hospitalisation. However, our coverage still isn't exactly where we want it to be. Our target for this first year has been 60%. So on the left-hand side here, you've got a chart showing the coverage in England at May. So we've got London at the bottom at about 46%, going up to the southwest region at about 62%. This chart on the right is some of our internal data showing sort of how the coverage has increased over time since the introduction. So you can see we started quite low last September, but now we're up to about 51%, which is really fantastic. Our team's been doing a lot of work with the maternity units and all the community who have put in a huge amount to implement this program and bring this in. And because we know there is quite a lot of variation across London, whether that's by maternity units or population. So we're trying with all of our partners to bring this up more equitably. So this slide here shows a bit of an overview of our childhood immunisations. So we know that the overall picture for childhood immunisations is that coverage is decreasing and that coverage in London is lower than the rest of the country, but there is quite a bit of variation within ICB, borough, but also kind of the lower LSOA level as well. We also know that London has some of the biggest health inequalities in the country. We've got a really mobile, I think the most mobile population. Alongside this, we've got lots of unregistered children, so children not registered with their GP. And also, as Susan mentioned at the start, we've got quite a lot of data kind of issues as well. So we know that this might be behind some of this, some of the reason why London's a bit lower. So on the left, we've got the London coverage of the 4-in-1 preschool booster at 24 months in the black, and then the MMR1, so the first dose of MMR at 5 years in the grey. And then on the right, we've got the same, but showing it at England. So this is data from 23-24. We have recently had the 24-25 data, and we know that coverage has decreased further. So we've got MMR1 going down to about 81%, but the preschool booster has dropped quite significantly down to about 64%. But as we've said, there may be other things behind this as well. So why is our coverage decreasing? We know that vaccine hesitancy is one of the biggest threats to global health. The World Health Organization has listed it as one of the the top 10, I think it's the 9th of the top 10 key threats to global health. And we can understand why. These headlines here, I just did a trawl through some of the major news headlines in the last month or so, and pulled up some of these. There were lots of others, and I'm sure there'll have been many more since I pulled the slides together last week. And this is worrying, definitely. However, we also know from studies that parents in the UK have a really high level of confidence in children's vaccination. These stats are from a parental attitude study done by the UK Health Security Agency, released earlier this year. So we know that 87% of parents agree that vaccines work for children, 85% believe they're safe, and 84% trust them. And actually, looking back on the studies from 22-23, these have stayed broadly similar. They have decreased slightly, but actually the attitudes towards them aren't changing. People also know that healthcare professionals and the NHS that's who they believe they can get the most information from and who they trust the most. So we know from all of this that actually it might not be about vaccine hesitancy. It's probably more about the accessibility of information about your vaccines, and the accessibility of getting a vaccine is also really important. And as Susan mentioned, some of the real inequalities that we see. So I'll hand back over.
Great. Thank you. And just as a final point, and then I think we're quite keen to hear from you. We tend to focus on a lot of times on sort of what doesn't work in the populations that miss vaccinations and why they're missing. And as JoJo said, we tend to focus a little bit on behaviors, but there's a lot of things that we have found as systems and as providers that we can do to improve uptake. And so we wanted to use a London-based study, which was one of the ones which, again, is not really about what's not working, but what it does work. And so one of the things during the measles outbreak we noticed was that the Tower Hamlets Bangladeshi community, which again is quite a cohesive community, but they had sort of bucked the trend. And so they had higher than usual MMR uptake. And there was a really good journal publication, the sources at the bottom, to sort of ask, so what is it that we can learn about high uptake, and what can we do to improve that uptake? And so it was some focused interviews, and it was a qualitative study. But what was really interesting is when you put together all of those different upstream factors, from the services to the providers and the cultural competence, to write down about the call and recall system and the messages, what you find is when all of those are put together, you do maintain that level of trust, and you do maintain that higher uptake. And that has to do with how accessible the services are, how the vaccine people speak to them, how they're offered the appointments, and all of that. So it's multi-level enablers. And so one of the things that we're trying to really focus on is looking at those end-to-end processes from the vaccines arriving to right down to when it gets into that delivery, to say, how can we improve that flow and how can we improve not just the appointments, but the accessibility. So the final bit is, because we do know that some of this, and most importantly, we have found with our communities, with our populations, and what our providers tell us is that 10 years ago, when they would go into a school or when they would go into a group, a community group, that people would, and this was reflective in HPV vaccine and other things, that people generally took the vaccine, didn't ask a lot of questions. What we found, particularly since the pandemic era, is there is a lot more personalization, a lot more people have a sense of coming into that discussion with a view about particular vaccinations. And so what we're trying to do is roll out training across all of our healthcare workforce about empathetic refuting interviews, which is basically about trying to find the time to really listen to that conversation and ask people, so before we assume that somebody is happy to receive the vaccination, it starts with really being empathetic, with listening, being familiar with that population and community. And it's about recognizing that vaccination, again, is not mandatory. It is an offer. And so it comes with something where we want to understand what is that person's perception and how can we do that better. So we have found through our training and through our staff, both allowing more time, having a culturally competent workforce, and having some additional training and listening to people with empathy and understanding some of their fears and their concerns is a much better way. But also having multiple offers, because sometimes people may not want to take up vaccination in that first instance. And that was, again, particularly poignant from the Bangladeshi study, but multiple studies have shown that is the key to really having conversations with communities, is getting people with and from those communities, and starting from a place of listening. And on that note, I think we want to now come to a place of listening and hearing your reflections.